All right, two more things to discuss about the spinal cord as well as the associated things. First off, starting off with the spinal nerves. So spinal nerves all crown the central nervous system. There are 31 pairs that we care about, all of which will branch off into an anterior and posterior root, which we kind of discussed about a little in the spinal anatomy. But they all, notice again, they kind of merge back together and then split off. You will have noticed, maybe you had a couple of bad flashbacks about muscle tissue and all that wonderfulness, and how there is an epimysium, paramysium, and an endomysium. Well, look at that. The nerves have a epineurium, perineurium, and an endoneurium. Wonderfulness. And that middle sheath, I would call it, that is a fascicle. All this nomenclature, this type of stuff should sound very familiar to you. So nerves, they look like this. They got, and intermixed with them are your blood vessels. You can notice that there are some red colored vessels here in this photo indicate artery blood, while the bluer is referring to the veins. Here is an anterior superior view of our spinal cord, a cross section. Again, there's the vertebrae, there's the dura mater. That postganglion again refers to that sensory neuron, with the motor neurons coming off from the anterior portion, all of which can branch off. They can be by themselves going off to innervate their corresponding organs, or they can branch together and merge together. That we'll get into in a little while. I do want to point out that each pairing comes off from in between each of those vertebrae and innervate specific portions. And that can be demonstrated or shown via these dermatomes. A dermatome is just a really fancy way of showing which nerve serves which part of the body in sensing. You'll notice that C2 is referring to the second pairing of the spinal nerve, C3 being the third, fourth, and so on. All of which, C referring to cervical, T referring to thoracic, L for lumbar, and S for sacral. Now these dermatomes, they're more of a sensory type of thing. They're demonstrating and showing in part where and which one of these nerves serves where. It also explains why shingles have their really interesting, very borderish presentations, we're going to say. Shingles is a virus reminiscent of varicella. If you had it as chickenpox as a kid, you're going to most likely end up with shingles when you get older, when it matures. It's a virus that likes to hang out. If you want to use appropriate terminology for microbiology, it's in a lysogenic portion of its cycle. When it's unabated, you're not seeing anything. It's in its lytic cycle when you actually start seeing the rashes. It's breaking out of the neuron and affecting the tissues around it. So you can see that it's sort of branching off this nerve. And maybe if I were to take a stab in the dark, based on its position that's in the axillary region, I'd say that it has a T4, T5, or T3 almost. I think it might be more of a stretch to say T3, so T4, T5 type of thing. Here's an FYI, neuropathy. Neuropathy just means that there is something going on wrong with the nerve. If the nerve is hurt or damaged, all of those sensory signals and motor signals and all that stuff gets disrupted. If you get an inflammation, it gets disrupted, and sometimes those nerves don't really know where that signal is coming from. So if it's an affected nerve or neuron, it's going to think, well, all of these nerves that they innervate, there must be something wrong with that body part. So you're going to feel it all throughout everything below that nerve and possibly above it too. So for instance, if you get, everyone loves the feeling of a funny bone. When you whack the funny bone, it just radiates. That's the term. It radiates down your arm. It goes, holy cow, the tingling sensation. Why won't it go away? That type of thing. You also have the something else that's a good demonstration is the carpal tunnel. One of the three nerves that serves your hand goes in between underneath this little band of connective tissue, I'm going to call it for now. If you overwork it, if you're typing all the time in a crooked position, you're not exercising, you're not doing the things that you need to help out your hand, you're going to cause inflammation in that region. That inflammation is going to also start beginning to rub on that nerve, which, in honesty, that's a very painful scenario. It just gives the pain in your hand, and it could potentially radiate up your arm through that nerve. You'll see that this blade is cutting into that. That's actually if you're not doing the appropriate exercise and it just continues to hurt, they can slice that so it relieves that inflammation. It does take away a little bit with your stability of those flexors, but not significantly. So with that, let's go ahead and dive into the plexus, the different types of plexi, beginning with the cervical plexus. Now remember that cervical plexus, I mean, any type of plexus is just where the nerves coming out of the spinal cord start to interact with one another. Axons go one way, axons go down, left, right, all around, squirrely squirrel, good, all that wonderfulness, kind of like my thought process most of the time. It's everywhere. Innervating with one another, trying to combine ideas. Same thing with the nerves. They're there in the plexus. They're there innervating, changing, redistributing the axons. And here is the chart that you probably would do well to familiarize yourself with, but the main one is this one right here, the phrenic nerve. The phrenic nerve, well, it innervates your diaphragm. If you were to get in a car accident or some type of traumatic issue were to hit you above C3 or hit you and cause a sever in that region, your diaphragm is going to be affected. You will become completely dependent upon a ventilation or a ventilatory equipment if you were to damage your spinal cord above that region. Because the diaphragm, if you please remember, is the one that's responsible for the majority of your breathing. Brachial plexus, that's the one, if you break down the word, brachial just means arm. So it's the plexus, or the gathering of nerves, C4 through T2 that serve and help out with actions of your arm, and to be honest, with a couple of other things that we won't talk about right now. When we were doing dissections, or when I was teaching at Idaho State University in the autopsy room, the main thing that we'd look at for the very end of that plexus is this M right here. This little M indicated the end of it. You'll see it's in the axillary region. Afterwards, the proper names for it, like the ulnar nerve, the median nerve, the radial nerve, these three right here, finally arise, and they're by themselves. There's no more crossing over at this point. They'll come down and serve and innervate varying types of portions of your hand, whether it be sensory or motor. Now, if there are problems or issues with any of the nerves or a part of that plexus, you can see any and what number of these. The Erb's Duchenne, I can never say that right, so I apologize. Palsy, I'd rather say the waiter's tip, refers to any damage to the plexus that involves the C5 through the C7 nerves. Now, why it's called waiter's tip? It is like you are trying to get into a very nice restaurant, but the restaurant has forgotten your reservation, and all the tables are booked. I am sorry, monsieur and mademoiselle. But perhaps if you were to give me a little bit of money, perhaps I could find the table for you. It's that they call it the waiter's tip because it kind of looks like that waiter is asking for a little bit of money to help you out in getting one of them seats. Now, this next part is a little bit more in detail. Really, all you need to know is that if you do get damage to C5 to C7, you get that Erb's Duchenne palsy that looks like a waiter's tip. Usually, this is the parts that is a little bit extra detailed just for you. So causes would be like trauma, obviously, C5 through C7, you get trauma there, somebody hits you hard enough, you get in a car accident, something like that, you could have the herb Duchenne palsy. You could also have issues during birth. You got a big baby coming through the birthing canal. Maybe its elbow gets hatched, shoulder gets in the way. Maybe the doctors pull on it a little too hard or something like that, and it causes that damage. You can actually see the baby's hand do the waiter's tip, like, Madame, merci beaucoup for giving birth to me, but I need a little bit of a tip, for I have come out, and you are still alive. I digress. Now, to help pull apart the herb Duchenne palsy and understand why it looks the way it is, there's a little table that I took from the NCBI archives. But it does help reflect and make things clear as to what's going on. C5, you can see it serves as a deltoid, the supra-infraspinatus, and the supinators, which makes sense. Supinators, remember that you're asking for soup. You have your palm up going, please, I want some mo. So you can't, if that's weakened or made incapable of moving, you're not going to be able to do that, so you get that hand down, or the pronation going, oh, this soup is crap, and you're pouring it out. Deltoid, you're not going to be able to really abduct it, abduct it. Supra-infraspinatus, that's the stuff that will help out with pulling back your arm or things like that. As well as the extensors of the wrist and fingers are affected, so that means the muscle tone is lost back there. And that flexor digitorum and the flexor carpi and all that stuff has its free reign, and it keeps, even though it's a light tone, it's still going to draw back that hand because it doesn't have the extensors fighting against it. Here's the complete list to help really pan things out and make it make sense. Remember that the diaphragm is part of the C4, C5, so you might have some issues with breathing, but because it hasn't affected C3 completely, it still has some ability to breathe. So again, what you really need to know about it, if you damage this, you get this. Reason why I pulled up all this information and made it as clear as, well, as detailed as possible was to help you understand. Hopefully you can pull apart and tweeze apart situations like this and diagnose what has gone on, just in case a CAT scan doesn't work or some type of issue arises when you are working in whatever situation you are as a nurse, whether helping give birth or what have you. Nerve palsy just refers to the 3 different nerves. Nice and clear because it's not really messing with the plexus itself, but the nerves that have separated or have no longer intermingling with one another. If something happens with the radius, you'll see that the radius controls the wrist extensor, so you're not going to be able to really extend that hand. You're going to get a kind of a wrist drop or a wrist droop. Ulnar nerve. If you remember, the ulna's on the more medial aspect of an anatomical position. So if you mess with the nerve on that side is most likely going to have oopsie whoopsies. The median nerve serves as, again, it's that carpal tunnel nerve. It controls the lateral side of your hand, including the sensories of it. So it makes it really difficult to flex that thumb and move that pointer finger and the birdie finger. Both, or at least partially, inhibit that middle finger because that ulnar nerve does have a little bit of sway on that ulna, that middle finger as well. Finally, the long thoracic nerve injured, you'll notice, I'm going to point it out here in the nerve plexus real quick, the brachial plexus really quick. It's that itty bitty thin one right there. That long thoracic innervates quite a bit of the muscles that are going to deal with maintaining that scapula. And if it's injured, you'll see something like you see here, there's my cursor right there, that you sort of form a wing. You lose that ability, that muscle tone to keep that scapula in the place that it should be. Again, there are your things that it serves. You'll notice that a lot of it has to do with serving your arm, making your arm move, making everything work appropriately. You got subclavius, the scapularis, the arm muscles. You got the pectoralis, which has a lot to do with moving your arm along the shoulder joint. So you're going through C5 through T1 here. C5 through T1. Let's move on down the spinal cord to the lumbar plexus. Here they are again. Plexus is all these different nerves are innervating one with another. If I were to describe it, I would look at the dermatomes and see. Let's scroll out there really quick. You'll see if we go back to that lumbar, L1, L2, L3, L4 have a lot to do with the front portion of your leg along with the upper portion of your hips and the anterior portion of your hips. So it has a lot of that sensation. It has a lot of the maintaining that pelvic space. So that is L1 through L5. Hence lumbar plexus. Then you got yourself the sacral plexus. This is where you hear, if you get the more seasoned veterans of life, the ones that have had 40, 50 years plus, they might have damaged or have sacral issues, and they might go, my sciatica, it hurts. It's referring to this little giant bundle. So there's the plexus. They're all coming together in this very specific sciatica with some of them branching off to do other things, but the majority of that back leg, let me point that out, the majority of that back leg and that foot are innervated by it. So if somebody has sciatica, maybe they've got an inflammatory response, maybe there's something wrong with a portion of their vertebrae, or maybe they've sat down weird and it's pinched or something like that. It's going to radiate down their back of their leg and they're going to feel that pain, and it's not a pleasurable sensation. Here are the nerves that apply to it or are part of the sacral complex. Notice that you start off at L4 and at S4 here. And also notice that you got a few nerves that deal with muscles, the back muscles. You got part of the gluteus maximus, minimus, medius. You got a portion of the buttocks. You got a portion of the sensory nerves for your exterior genitalia going on right here, as well as certain muscles to help with that system. But you'll also notice that the majority of the lower leg, that leg has served by that sciatica. With that, if I were to have any parting thoughts, I would say I would probably refer back to my thought in my story about when I shadowed a doctor when I was considering medical school. There was one person that had come into the office and was saying, hey, my groin was hurting. My groin is absolutely in great pain. I think there is something wrong down there. And I need you, doctor, to go ahead and order me an x-ray of this issue. Now, if you looked back at the patient history, you would have seen that he had issues with his back. So the number one thing that the doctor is thinking is, okay, there is obviously something wrong with some type of complication, most likely arose because of his back. But being a good doctor, he worked out a deal with him. They worked because the patient was absolutely refusing to listen to the doctor about how we should check his back. So I guess the moral moral of the story that I was going to share you is work with your patient, because what he did was that he said, okay, let's go ahead and get a test to check with your back. Let's also go ahead and give a test to figure out if something, some blood, as well as some other samples to make certain it's not something with your groin. So he worked it out, perhaps somewhat in his favor, because it did help him out with a little bit of extra testing, but it also helped alleviate the patient. So that's something that, as you do patient care, I would remind you to please be mindful of the patient and their opinion.